Welcome to Discovering True Health, where our goal is to provide you with cutting-edge health information through research, interviews with experts, and personal journeys to true health. Our message is a message of hope and healing, and our mission is to bring you on a journey to discovering true health, to not only find wellness, but to thrive. Hello, everyone, and welcome to Discovering True Health, your weekly deep dive into health and wellness. Thank you so much for joining us today. Don't forget to hit the subscribe button to stay up to date on all our upcoming shows. You can also check out additional information on our website, Instagram, or Facebook. All those links are below. So today we'll be talking about chronic pain and, most importantly, how to resolve it. I myself have lived with chronic pain for years from a car accident, so I am really looking forward to learning from my guests today. Now, there was a survey done in 2019 in the US called the National Health Interview Survey. They found that 50.2 million adults report pain on most days or every day, and they state chronic pain is among the most common chronic conditions in the United States. Now, this is from the mayoclinic.org. Chronic pain is a serious health condition that can cause new or worsen depression, anxiety, and difficulty sleeping, and I can relate. And it can make it more difficult to keep up at work, manage tasks at home. It can lead to problems in relationships and financial instability, and reduce overall quality of life. So it's not only a major health issue, but it can also lead to many other health issues if not addressed. So I have on today with me Dr. Mitchell Yass, who is creator of the Yass method, which is a method for diagnosing and treating chronic pain that he's developed over 20 years, treating thousands of patients, resolving their pain, and returning them to full functional capacity. He's also author of the Pain Cure RX, which is the Yass method for diagnosing and resolving chronic pain. And he's been featured on PBS, KTLA5, and several other major news networks. So welcome, Dr. Yass, and thank you so much for joining me today.
Thanks for having me. It is great to be with you, Christy. Hopefully we're going to spread a lot of knowledge and let people know that resolving their pain and getting their function back is much easier than they think.
I love that. Okay, so now you have talked about how chronic pain has exponentially increased since the 80s. Can you talk about why this is and why it's become such a major global health issue?
Yeah, so it's been going on for 40 years. So I think many people who are suffering from chronic pain think that this has gone on throughout the history of mankind and it's just a continuum. I need people to understand that chronic pain never existed in the history of mankind. Never. Not until the late 1980s, beginning 1990s. So as a person who's trying to really understand the overall essence of chronic pain, you have to look at it from cause and different factors. Well, I think it's important to look at it from a historical perspective as well to get an understanding. So why at the late 1980s, early 1990s did chronic pain begin? And the answer is automation, higher levels of computer usage, things of this nature. The advent of the computer and automation and the cell phone has allowed people to do more and more, utilizing their bodies less and less. And like, to me, the classic example is if I had to get money out of the bank, I would walk into the bank, there would be a teller there, and I would have to give them, maybe some people are too young to remember this, but this is the way it used to be.
Back in the day.
You'd give them a withdrawal slip or a deposit slip, and they would take care of it, and then it would be gone. So that person was sitting there giving you money, doing transactions, and so there was a physical capacity. Well, now that job was taken by the ATM, a computer, right? When I was very younger, worked in a stockroom. I had to go up and down ladders and fill boxes, and there was a physical demand. Robots do that now. So there's a guy sitting on a computer looking at a robot, right? What's the number one job occupation in the world today? IT. People sitting on computers 8 to 10 hours a day. So what you began to understand is that with this higher and higher level of technology, people are physically using their bodies less and less. So as a result of that, if you don't use your muscles, they weaken. Then when you do decide to use them, they're simply not capable of creating the output, the force output necessary, and they strain, thereby eliciting pain. That's why more and more people have ended up having more pain. If you want to see it in a age-based concept, prior to the late 1980s, early 1990s, what was the average age of somebody that would be complaining of pain who actually was feeling pain? It was retired people, late 60s, 70s, and 80s. You've heard the phrase, again, if you're older, you've heard people talk about, oh, I had rheumatism. It's my rheumatism, right? That was old people, right? Well, look now, I treat 20-year-olds. I treat 30-year-olds. I treat teenagers. One 20-year-old girl told me that her head feels like a bobblehead. She can't support the weight of her head.
Wow.
Well, why is it different now than any other time? Well, that 20-year-old is looking at her laptop or a cell phone in this position. And if you look at my head from the side, she's sustaining her head so that it's not supported over her cervical spine, which is where it should be supported. Having it forward is creating a load. And that load has to be absorbed by muscles. Well, those muscles weren't designed for that load, especially when you just haven't used them to the same extent. So they strain. So that's the answer.
That's interesting, because I remember when I was studying to be a personal trainer, it said in the book, it was talking about obesity and how, why past a certain age you gain a certain percentage of body fat. And it's because you're living more sedentary of a lifestyle. You're not moving around as much like you were, in your 20s. You're now sitting more, just sitting around doing less, but that's now not like a middle-aged thing anymore.
Not at all. It's
Yeah.
all ages. It's all ages. And I mean, to really understand how significant this is, if I was sitting on my couch and I didn't like the television show I was watching, if this was the 1970s, I had to stand up, go over, turn the dial, pick the TV show I liked, and walk back.
Right.
Now I don't even have to use my I don't even have to use my thumb. I can or my fingers. I could just talk into the remote and say, change to channel 5, and it does it.
Right. So even watching TV, you had to do some sort of activity.
I mean, literally, almost pretty soon, you're just going to have some robot who's going to bring you food from the refrigerator to your recliner, and you're literally not going to do anything.
Exactly. You're just pushing buttons, or you're speaking to it.
and that's the answer. That is the reason for a global chronic pain epidemic. Truly.
Wow. Technology. We need to figure out how to counter that. So now
Absolutely.
You have created the Yass method. Can you give us an overview on how you developed it and what it is? And then we're going to get into more specifics and details about it.
Sure. So people are having chronic pain and they're trying to get treatment. Typically, they always start with the standard medical practices, orthopedists, neurologists, chiropractors, physical therapists. And typically, the way that they're getting their treatment is based on getting a diagnosis, typically through an MRI or X-ray. That's where they identify it. And then they get treatment. And they're in chronic pain because those treatments aren't working. So maybe then they're going to go on to some alternative types of treatments, maybe acupuncture or some of the other things that are out there. We were talking prior about pulse therapy, or there's different types, just a lot of different types of alternatives. And so at some point, they end up just getting treatments. Now,
maintenance.
Right. Well, the hope that the treatment is going to resolve the cause of the pain, thereby ending it from being maintenance to an actual completion and living pain-free and fully functional. What people need to understand is that you can't get a treatment until you've gotten an appropriate diagnosis. And I want to just break this down for people, because this, to me, this will explain why MRIs and X-rays don't work. So what is the diagnosis? Well, if you know that pain is an indication of a tissue in distress. So the tissue in distress, it's not working properly, and it needs you to know it's not working properly. So you get an intervention to fix it. So it emits a certain type of pain, a certain symptom. All these different tissues create different symptoms. So if you have irritation in your mucosal lining, you'll sneeze. If you have irritation in your throat, you cough. Well, if you have pain, it could be from a different types of tissues, and depending where the pain is, what brings it on, that's going to help you understand that. So the symptoms are being created, and so if you recognize that each tissue creates a specific symptom, the only real way to know what tissue is creating it is to look at the symptoms themselves, because each tissue creates specific symptoms. So from interpreting the symptoms, I can tell you what tissue is creating those symptoms. That is the basis of the Yass method. Now, the concept here is that for you to get treated, you needed the right diagnosis. Two parts to the right diagnosis. You got to name a tissue. Okay? So CRPS, which is a very common diagnosis out now, complex regional pain syndrome, or fibromyalgia, or patellofemoral syndrome, these are just diagnoses that are not identifying a tissue. So they have no value. You're in a car accident and you're diagnosed, here's a very popular thing, whiplash. Can you point to whiplash on an anatomy chart? Because I don't think I can. I'm pretty sure there's no tissue named whiplash. So as a result of that, if you go through your process of being treated with the diagnosis whiplash, how do I know what tissue is in distress? How do I know if I'm resolving the stress of that, thereby ending its need to elicit my pain? You don't. So number one, you need to have a tissue identified. Here's the mother lode right here. The second part of the diagnosis must be that the symptoms being experienced by the individual must be the exact symptoms that the tissue identified would create if it was in distress, because that's the only way of saying that that tissue is creating the symptoms the person's experiencing. I'll give you an example. Let's say you're having pain around your kneecap. Lots of people have pain around their kneecap. They get an MRI and it finds that they have a meniscal tear. And they're told that since the meniscal tear is found at the time they're having the kneecap pain, it must be the cause. Okay? So, number one, did they name a tissue? Yes, they did. A meniscus. Number two, is the pain being experienced where it should be if the tissue identified would be in distress? The meniscus lies between the thigh bone and the lower leg bone. And there's actually a second joint to the knee, the joint between the kneecap and the thigh bone. That's the joint where the kneecap runs through. Well, the meniscus lies between this joint. So if it was to cause pain, I better experience pain between the thigh bone and lower leg joint at a point called the joint line. But I don't have pain at the joint line. I have pain at a completely separate joint around the kneecap. Therefore, the rule has been broken. The meniscus would cause pain somewhere than where I'm experiencing that pain. Therefore, by definition, I don't care if God himself comes down and says it's true, it can't be. It can't be. It breaks the laws of what a proper diagnosis must be. Therefore, you can't get treated for that meniscus. You have to try to figure out what tissue is in distress creating the pain around the kneecap, and that's typically muscular, relating to the front thigh that attaches. That's what differentiates the existing global medical use of x-rays and MRIs versus the singular guy who uses the premise of diagnosing through interpreting the body's presentation of symptoms to identify what tissue is in distress, eliciting those very symptoms being created, experienced.
Got it. Now you talk about, and I think this is really informative to understand where the pain's coming from physiologically and how it works. So in your book, you talk about the 4 primary ways muscles cause pain. Can you break those down and give some examples of each one of those for us?
Sure. So people are going to question, well, why should I go to this guy? Okay. All right. At least so far, it sounds like what he's saying is true. So I guess I'm going to get a correct diagnosis after being in pain for 5 years, 10 years. At least I'm probably going to get a right diagnosis. Well, here's the magic. This is where you're going to really want to get treated by the Yass method. Over 28 years and close to 15, 16,000 people, I have shown that in more than 98% of cases, the cause of pain is muscle. Muscle is the tissue in distress responsible for 98% of cases I've treated over 28 years. Now, people are going to say, that's crap, man. There's no way. Okay, if I have pain in my muscle, I can see that happening, but my pain is in my joint, or my pain feels like it's a nerve. Well, here's the way it works. I'm going to give you the 4 mechanisms that relate to muscle that you will see when I describe them. If you're listening to this, you're going to say, oh my God, that really does sound like that's the cause of my symptoms. So first, let's take the obvious. Okay, I got pain right here, right? This is the upper trap, levator scapula. All right. Well, that muscle, levator scapula in Latin, elevate the shoulder blade. So that muscle, although you'll be convinced relates to the cervical spine, actually attaches to the shoulder blade. So there's lots of muscles that relate to the shoulder blade that keep the shoulder blade against the rib cage. So the muscles of the shoulder that attach from the arm to the shoulder blade can move the shoulder. So if some of those other muscles break down, the levator scapula may have to overwork and elicit pain. So this is a case where it's the most obvious people think about. I have pain in a muscle. Although for the average person, they might not be adept enough to know it's a muscle, and they might think it's coming from a nerve and anything. But if you press on it and you say, yeah, that's my pain, you have to understand you are in fact pressing on a muscle. So we have muscles not working, causing another muscle to compensate, breakdown, and elicit pain. Let's go back to our kneecap concept. You are having writhing pain in your knee, around your kneecap. You can't stand, you can't go up and down stairs, you can't kneel. Sitting trying to drive is a horror. What am I trying to point out here? There's a general perception. Well, my pain is so severe, how could it possibly be from a muscle? I'm telling you, it could be severe enough to put you in a hospital, and I've treated many people who have had it that level. So just as I said, the pain is so bad in around your kneecap, you can't go upstairs, you can't wait there. Here's the concept. The kneecap runs in a groove at the end of the thigh bone called the intercondylar groove. If you have your knee straight and you bend your knee, that kneecap is tracking up and down in this groove. Now, there's a certain tension on it to keep it in the groove, but the tension that's on that kneecap is based on the muscle that sits on top, called the quadricep muscle, thigh muscle. And that's attached to the kneecap via a tendon, the quad tendon. So the amount of tension that the kneecap has as it's running through the joint is directly related to the amount of contractile force in the quad, your front thigh. Now, if the quad ends up being stronger than the hamstring, which it can be, especially for those people who like to go to the gym and think they're doing the best thing for themselves, but they find that they love to do knee extension, not so much hamstring curl. They like the quad stuff, and everybody always, I love going on the leg press. I love doing knee extension because it's in front of you and it's kind of a muscle you see and you can see what you're doing. So if you were to create an imbalance, well, the quad will have a tendency to shorten. When it shortens, it's actually pulling up on the kneecap excessively. So when you go to bend that kneecap isn't just gliding, it's compressing. And you have pain around the kneecap. What is the cause? Is it structural at the knee joint? Nothing structurally wrong. It is specifically the quad. How do you know that? Because you'll say, I have pain when I'm going up and down stairs or when I'm standing or kneeling, but as soon as you sit down, the pain is gone. If it was structural, wouldn't it be there 24 hours a day, right? Because the structure doesn't change every time you sit down and stand up. That's one of the key indicators you have a muscular problem, regardless of what you're being told on an X-ray and MRI. If your pain is associated with activity, it's muscle, all right? So we have the strained muscle, we have the pain at the joint. Here's another one. Again, nobody knows about this. So can muscle refer symptoms? Everyone knows nerves can refer symptoms. Can muscle refer symptoms? Let's look to the body and see if we have an answer. I'm having a heart attack. Where do I have pain? At the chest and the left arm. Is there anything wrong with my left arm? No, nothing wrong with my left arm. I'm having pain there because it's being referred from where? My heart. My heart is literally sending signals there because That is the classic symptom associated with a heart attack. And it's trying to say, I'm having a heart attack. I need you to help me, right? What's the heart? It's a muscle. So clearly muscles can refer. All right, let's go to the classic. Person's laying on their side when they're sleeping. They wake up, their hand is numb. Is that referred from a pinched nerve in the neck? No, no, no. What happened was the arm bone should be centered in the shoulder joint, but because your rotator cuff is weak, the arm bone gets drawn a little too far forward, overstretching the rotator cuff muscle, irritating it, and that then refers symptoms down the arm. How do you know I'm telling you the truth? Just look up something called a trigger point chart. That is a chart that represents if there are trigger points in a muscle where it will refer symptoms. And the muscle I'm referring to is an infraspinatus. If you looked up infraspinatus trigger point chart, you'll see that it shows the point here and the symptom going down the arm directly to the hand. How do you know I'm right? Well, as soon as you stand up, shake your shoulder a little bit, it goes away. If it was a herniated disc or a pinched nerve, you're telling me shaking your arm is going to make it unherniate? That would be miraculous. Okay? So that's 3. The muscle can refer. And fourth, the holy grail of them all, a muscle can strain and impinge on a nerve. What does that relate to? Sciatica. 40 million people in the United States a year suffer from sciatica, and they're being told it's coming from some aspect of the lumbar spine impinging on the sciatic nerve. Ladies and gentlemen, I will say this bluntly, accurately, and as clearly as I can. No nerve attaches to your spine. Period. End of story. Nerve roots come out of your spine. They form nerves somewhere away from the spine. The sciatic nerve begins in your butt, in the gluteal area, and ends at the back of the knee. There happens to be a muscle that sits very close to it, and in 30% of the population, the nerve goes through it, called the piriformis muscle. So if the piriformis muscle were to strain, it can thicken and impinge on the nerve. So you are having a neurological symptom. I'm not denying that. But it is not due to some structural variation of the nerve. You are not having neuropathy, which is a baseless diagnosis. You are having a strained muscle impinge on a nerve. And in fact, sciatica should be perceived as relating to hip dysfunction, not relating to spinal structural variations. Those, if you were listening, I think that you would say one of those sounds very much like what's creating my symptom. And again, 28 years, over 15,000 people, I think I have the evidence theoretically and clinically to say that that is in fact true.
Now let's take the last example you talked about, sciatica.
Yes.
How does, let's say mainstream medicine treat that, and how do you treat that?
So the way everybody has the symptom the same. It's from, if you are in fact having pure sciatic symptoms, it's pain in the gluteal region in the butt, and it runs down the back of the thigh and then must pass the knee. I can't tell you how many people had a symptom that was not sciatica and they were told it was sciatica. If your pain ends at the back of your knee, you do not have sciatica, you have a hamstring strain. Nerves pass joints, muscles go to joints. So you have to have it from the butt down the back of the leg, not the side of the leg, not the front of the leg. It must be down the back of the leg beyond the knee, typically to the foot. So you have this symptom and you're just writhing in pain. You're going to go to the medical system. They're immediately going to go for an MRI. And they're going to find a herniated disc, stenosis, arthritis, a pinched nerve, compression, something in your spine. My point to everybody is, let's just say you're over 40 or 50. Do you think that during the course of your life, maybe you did some physical stuff before technology hit, and maybe you were a tennis player or a golf, or maybe you played football in high school, or whatever. Maybe you do a physical job, and all right. Do you think that you're going to have some level of wear and tear on your body over 40 or 50 years? And therefore, if I were to take an MRI of anyone on this planet over the age of 40 or 50, blonde hair, brown hair, 6 foot, 5 foot, in pain, not in pain, do you think I'd find a structural variation somewhere in your body? Please, let's all agree that's true. Can we please all agree that's true? So the fact that it's found when you have pain is meaningless. It's meaningless. It's called correlative theory. They're saying that since the pain is the structural variation, the herniated disc is found at the time you're having your pain, it is asserted to be the cause of your pain. I would then say, well, at the same time you're having pain, I do an MRI, I find you have two elbows. You have two elbows. Don't everyone has two elbows, I think, typically. So how come I can't say two elbows is the cause of your sciatic symptom? It's the same exact theory. That's correlated theory. That's called junk science. That's why you have chronic pain. Chronic pain occurs because of misdiagnosis. If you went to the medical system, you would start maybe with some epidural nerve blocks, some pain medication, stuff like that. Eventually, when that didn't work, take a guess where you're going. You're going to a discectomy. You're going to a what are the other ones that they have going on? Discectomies. I forgot what the other thing where you take a piece of the bone away, and when all those fail, you're going to move on to fusions, right? And you're still going to have your sciatica. Why? Why? Because the tissue identified is not the tissue in distress eliciting your symptom. It's a muscle impinging on a nerve. So eventually they'll say, hey, we've done as many surgeries as we can. You're probably going to have to live with this, or we could just get you to send you over to pain management. You'll stay addicted to heroin for the rest of your life, which are what opioids are. Now let's go to you decided, you know what? I've heard too many bad stories about that. I'm going to try this Yass guy. So what you're going to do is probably we're going to do a Zoom session, and unless you happen to live somewhere close to Jacksonville, Florida, but the majority of what I do is Zoom session. And so I'm going to confirm your symptom by listening to you. You're going to tell me what brought on your symptoms. You're going to tell me what makes your symptoms bad, what makes it worse. And we're going to just absolutely confirm that you, in fact, have sciatica. Now, as I mentioned, sciatica is typically caused by the piriformis muscle straining. Well, that only happens because hopefully anyone watching will see I'm pointing to a muscle called the gluteus medius muscle. This is the muscle responsible for balance and stability. If you were to take this leg off the floor, the only reason you don't topple to that side is because this muscle contracts, pulling on the pelvic rim down towards the hip, bringing the opposite side up, maintaining a level pelvis, which is where you have balance. So that's why you could take this foot off the floor. But if this were to strain, you're going to collapse, right? And the body wouldn't want that to happen. That's why it says to the piriformis, try to assist. The piriformis sits right next to that. So I would, if this was the cause, that this strained first and then it was the piriformis, well, I'm probably going to find you're not going to have a level pelvis. It's impossible. You can't have a level pelvis because the glute medius on both sides are unequal in strength, sustaining a level pelvis. I'm going to try to check and see what's your ability to single leg stand. And one of those sides, it's going to be really bad, whichever side the glute medius is weak on. So I'm going to say, all right, I'm going to provide you a narrative. The narrative I tell everybody they should get before they get any treatment. And I'm going to say that I believe that the cause of your pain is the strained right glute med, causing the piriformis to then compensate, strain, and impinge on your sciatic nerve. I know this because the left pelvis is higher than the right side. You have a greater difficulty single leg standing on the right side. When you go to walk, you shift your body completely over to the right side because you won't allow the glute med to support you. I tried to have you do some tests, and it was apparent that your glute med is weak. Therefore, I am going to resolve your sciatica by strengthening the glute med, the quad, the glute max, and the muscles that support the arch.
So you fix that imbalance, correct the imbalance, and that in turn corrects the nerve impingement that's going on.
I'm correcting the strength deficits that are leading to the piriformis straining, ultimately impinging on the nerve. People have to understand what I'm saying. There is nothing structurally wrong with your sciatic nerve. When people say neuropathy, and that's what people will be diagnosed with, neuropathy, break it down, neuro, nerve, pathology. They're trying to imply that there's a structural variation to a nerve. Nerves don't vary. That's not the way it works. If you have a disease entity, muscular sclerosis, all your nerves go to crap. That's the way that works. But individual nerves don't just arbitrarily have pathology. You're more apt to have a muscle impinge on a nerve than degradation of a nerve. That's a critical thing to understand. Your tissues don't run in tunnels. It's not like there are these tunneled highways in the body and my artery goes here and my vein goes here and my muscle goes. That's not the way it works. Your tissues are constantly within proximity of each other. And muscle, because of its responsibility to allow us to function, is the one most apt to break down. And if it breaks down close enough to another tissue, it could affect a vascular issue. It could affect a neurological issue. I have people who have vertigo. You know what the reason is? Because there's a muscle here called the anterior scalenes. And if that strains, when people end up with this forward shoulder posture, it could actually impinge on an artery called the vertebral artery. It sits right next to it. Everyone knows the carotid artery. The carotid artery only provides blood to the front of the brain. The vertebral artery provides blood to the back of the brain. So if a muscle was to compress it, wouldn't that limit blood flow to your brain? And you would feel dizzy. So I've literally had people struggling with vertigo, massaged out their neck, strengthened their upper back muscles, pulled their shoulder back. End of story.
Wow. Fascinating. You know what I love about the way you see everything? It reminds me, I did an interview recently with a naturopathic doctor, and you see the whole body as this, as a whole, and you find root causes instead of like separating everything like you were talking about.
Well, you're actually hitting on what's the problem? What's the problem with the existing system? So if you go to a neurologist, are you ever going to be told the cause is a bone? If you go to an orthopedist, you're ever going to be told you got a nerve problem? If you go to a podiatrist, is he ever going to say anything other than the pain's coming from your foot? Everybody's splintered. The rheumatologist is always going to tell you got an arthritis issue, right? Yeah. So you've developed a splintered system. And as a result of that, every person you go to is trained in one tissue. Now, if the cause of your symptom is a tissue outside of that, what do you want them to do? Do you think every one of the doctors you're going to go to is going to say, I got to be honest with you, I don't think that what you have falls in my purview, so I'm just going to have to let you go? You would literally be going from orthopedist to neurologist to rheumatologist, and just everybody's telling you, right. I don't know. It's more apt that they're going to say, not exactly so interested in your symptoms. What I have been trained to do is look at structural variations, and wherever they are, when they fall under my purview, that's what I'm going to treat. And if anyone disagrees that that's the way this system works, you're not being honest with yourself. You have to know. I've treated thousands of people globally, man.
Yeah, you're getting
go to these people.
Fragments of, information.
They're just fragmented. Yeah. It's too fragmented. Yeah. So I have a degree in physical therapy. I was one of them. But what happened was when I was telling you the story just before we started it, it's one thing to go to school for this stuff. You learn and you're trying to get good at this stuff. The next thing happens is the first day someone's in front of you and they're writhing in pain. Maybe they're telling you that it's a mother that can't hold their kid or a guy who can't go to work. And all of a sudden it's soberingly real. They're in front of you and you're supposed to help them. And you got this educational background. And most people would just take it and do whatever they were told. Okay, just get on the desk, on the table. I'm going to ultrasound you. Okay, whatever. And something very strange happened to me. And I really don't know why. The person was standing there, and it just seemed like the most logical beginning to the conversation to say, could you just point to where your pain is? And when that began to happen and they were coming in with a diagnosis based on an MRI, it was turning out that where they were pointing to wasn't where it was supposed to be based on that MRI finding. And I found myself in a situation where I was like, do I follow the education or do I follow what the person is telling me? And being this just on, by the way, I went back to school at 30 years old. This was a second career. So I was a little older, a little wiser, maybe a little more mature. And I was like, I really, really want to help people. That's why I was going to do this. So I was like, let's just follow the path of seeing where this is going to go. And I had some understanding of muscle and stuff. And sure enough, along with their pain being in the muscles, I was finding postural variations. I was finding movement pattern problems. So I said, you know what? No one's really paying attention. I've been left on my own to do what I want. Let's just do some massage of muscle. Let's strengthen some muscle and see what happens, even though they were told it was a pinched nerve. And within a treatment, 2 treatments, they were pain-free and fully functional. And I was like, oh my God, this really is working. So I'll just keep it on the lowdown. I'm really not going to talk much. I'm going to say, hey, I'm going to just try to give you some, I'm going to do an evaluation. I'm just going to try to do some treatment. Let's see what happens. And as long as I was giving them the results, they didn't care. You could say it was their hairline. Who cares? They were out of pain and they were living their life. So they were ecstatic. And that was how it started. A year and a half after I graduated, I opened my own practice. And now I was free. I could say anything I want, do anything I want. And I really used it as the opportunity to experiment on what I was thinking and started developing theory. I'm having empirical improvements. Now I want to try to create my own theories as to why, because I wanted to be able to say, if I'm having this improvement, I want to now replicate it over and over and over again. And as you get bigger, people are coming in, they're starting to work with you, and you're going to have to explain what's happening. So that's how the development of my theory really began. Within weeks of me being a practitioner, I was already beginning theory.
Wow. Now, what about sustainability? So, somebody comes into you, they have this pain, you work with them, you kind of get to the bottom and find the imbalance or what's going on. If they have a muscle imbalance or something like that going on, are they going to forever need to be doing certain exercises, or what's the sustainability as far as the treatments go?
Right. So the way this typically works, as I said, is we're going to have this treatment and we're going to establish that it's a muscular cause in more than 98% of the cases. I'm going to figure out which muscles. So now we're going to do the exercises. So I'm going to demonstrate the exercise. And by the way, I don't know if I said it. All you need is a resistance band and a chair. Resistance band and chair. That's all we need. That's the total amount of equipment we need. So I'm going to teach you how to isolate the individual muscles. If you want to strengthen muscles, you need to cause the muscles, every muscle causes one joint to move in one direction. So we have to set them up in a situation where the rest of the body is stabilized, and then we're going to perform this exercise to which they're going to move one joint in one direction. The bicep is this. If I wanted to do the lower trap, it's this. You'll see one direction, right? And now we're going to apply the resistance. So what's the essence of this? What we're saying is you're having symptoms because the force output of 3 to 4 specific muscles, not all your muscles. That's why you don't strengthen everything. If the symptoms are on one side, you don't do both sides, because that's actually sustaining an imbalance and sustaining your symptoms. So we're going to just work the muscles responsible for your symptoms. So we're going to cause the muscles to adapt to a greater and greater resistance, thereby increasing their force output. Now, once the force output of that muscle is greater than the force requirement of their activity, as long as they sustain that strength level, they're asymptomatic and they're fully functional. So all we're ever doing is we're measuring how much force output the individual muscles required to do activities are versus the force requirements of the activity. So let's say that you were walking a mile and you ended up getting knee pain. Okay. So we know that the force output of specific muscles in the leg are less than the requirement to do a mile. So we're going to do exercise and we're going to start to strengthen. Now, what are we going to do about your function? Well, we know a mile you can't do because that causes pain. So what I'm going to do is I'm going to say, go walk a half a mile. And we're going to test it. So if you are asymptomatic, no symptom at a half a mile, what does it say? Well, we know that you have at least enough strength to do a half a mile. So that's good. So now we're going to stay there. Now, what we might ask you to do is go 3/4 of a mile. What are we going to find out at 3/4 of a mile? Oh, you got pain. So what does it tell you? You have enough force output for a half a mile, but not enough force output for 3/4 of a mile. So what we're going to do is I'm going to keep strengthening you. And you're going to be progressing your resistances, and it might take a week or 2 weeks or 3 weeks. And all you're going to do is just keep walking a half a mile, just because I know it's not going to hurt you, no symptom. And then in about 2 weeks, I'm going to say, all right, go try to walk the 3/4 of a mile. Guess what's going to happen? You're going to walk the 3/4 of a mile. You ain't going to have no pain. Because why? We took time to progress the resistances until the force outputs responsible for walking the 3/4 is there. Force output's greater than force requirement. Congratulations, you're at 3/4 of a mile. Okay, now let's check that mile. Still got pain. Okay, 2 to 3 weeks. Let's keep increasing, progressing those resistances, but still keep walking at 3/4 of a mile. Couple of weeks more. What are we going to find? Wow. You could walk the mile. What did we accomplish? We created a situation where the force output of your muscles is greater than the force requirement of the mile. Congratulations, you've achieved your fantasy goal. So where do we go from now? Well, if the most you ever want to do is a mile, just stick with the existing exercises, sustain the force, the resistance levels of that, you're gold. You'll never have a problem. But what if one day you said, I really, really want to walk a mile and a half. I have this fantasy. Try it. Try it. What if you have pain? It tells you don't have the force output. Strengthen your muscles, 2 to 3 more progressions, and at some point in 2 to 3 weeks, walk it. You'll be able to do it. That's life.
And I guess at some point, the one side of your body will equal the other side.
When you're asymptomatic, right? I should have said that. When you're asymptomatic, what that's saying is that most likely now the strengths of both legs are equal. So at that point, now we're going to begin to progress the resistances on both sides because we're assuming they're equal and at least pain-free at the level of activity you're doing to allow you to be pain-free.
Got it.
So now if we want to start bringing up our ability to do activity, now we're going to strengthen both. That's when you do both.
Got it. Fascinating. Now, you talked a little bit about one of the diagrams in your background. Can you touch on the diagrams in your background?
Yes. As far as I'm concerned, there isn't a Zoom session that I don't incorporate one of these 4. Whenever I do, I'm a panelist on a show, or even if I do sometimes podcasts and people ask specifics, this is the essence of life, these 4 diagrams. So we'll go to this side first. All right. If you have a migraine headache, what are the options that the medical system gives you right now? Ask Serena Williams. Ask Serena Williams. What is the only things you can get? It's medication. And she's happy to promote that. And of course, then there's the famous Botox injections.
Right.
Okay. Right. So in either of those cases, what is the tissue in distress? How are you resolving the distress of that tissue? You ain't. End of story. I don't care what they're telling you, what the magic is, whether she's playing tennis or playing with a kid, or I don't care. The reality is you are not her. You have a migraine headache. You need to understand what the tissue in distress is and how to resolve that. Now, man, it could be a tumor. It can be a stroke. So you go through all the testing when it comes to migraine headaches. But what happens when it comes up high and dry? They don't have an answer. Can it be muscular? Is it possible? Would a muscular deficit, a strain of a muscle, show up on an MRI or an X-ray? No. No muscular. All those 4 types of mechanisms I told you, not one of them shows up on a diagnostic test, which is why the medical system basically is left to give you injections and medications. All right, I'm going to teach. I'm going to teach you something. So here's the skull. Here is the upper trap. And below that is the levator scapula. It attaches to this bone here called the spine of the scapula. It is part of your shoulder blade. Okay, so typically what happens is because people end up with forward head posture, forward shoulder posture, the head moves forward. The ability of these muscles to support the head are jeopardized. They strain and they shorten. So the more the head moves forward, the more this has a tendency to elevate. Okay, so how do we stop that process? How do we not only stop the straining, but pull the head back? Well, if we know that the head is attached to the shoulder blade based on this muscle, what if I was to take the shoulder blade and pull it down your back? If I pull it down your back, that's going to cause this point to come back this way, and your head's going to come back and sustain your head over your cervical spine, which is the way it's designed. Is there a muscle that's connected to the shoulder blade that actually is in a position to pull it down? The answer is yes, the lower trap. Let me explain. This muscle attaches to the cervical spine down to the bottom of your rib cage. You know where the bottom of your rib cage is? That's where this has leverage to pull from.
Wow.
It's in an amazing position. So if I was to strengthen this, I could suck this down, pull your head back, take all the tension off this, and of tension-based migraine headache. And I have done it for people with cluster headaches. I don't care what the story is. And it happens fast. Weeks, not years, not injections, not medication. If you have a tension headache, you need to fix the muscular deficit. In most cases, it's that. That is the mother lode right there. And in terms of people having shoulder pain, oftentimes the problem is that the shoulder blade isn't being held against the rib cage, so that the muscles that are attached from the arm to the shoulder blade to move the shoulder don't have the ability to create the leverage, and they strain. So this is a critical muscle. When we talk about here, I always talk about, people always talk about what are the great evolutionary elements that have made man. They talk about fire. They talk about the wheel. I want everyone to understand this. You don't stand on two legs unless you had an exaggerated gluteus medius muscle. Now, the wild thing is, I was teaching my daughter this, and I'm like, I think I actually figured out this may be the greatest evolutionary change. And so I said, you know what? Let's go to the Jacksonville Zoo and let's look at an ape, because an ape is bigger, but I want to see what is the relationship of its pelvis to its torso compared to man. And we go and we look at this ape. And the most amazing thing is that the ape has a pelvic girdle the 10th of the size of a human. It's so small.
Wow.
And what I noticed was its arms are so elongated that that's what allows them to technically walk on fours unless they have to run. And that can only be for short distances. And when he runs, he actually does what's known as a kind of waddling thing because his glute medius aren't strong enough. So as I had mentioned before, if you ever want to take that foot off the floor, you should fall because you only have one point of contact to the ground. So what has to happen is this muscle attaches to the top of the pelvis and to the hip joint. So the muscle pulls on the top of the pelvis, pulls down, causing if you pull this side down, this side comes up. And the only way that you could have balance, in the sense that you're not going to fall to the side, is when these two heights of the pelvic rim are level. So that's what controls that. If this were weak, this would drop. The distance between here and the floor would decrease, and you're susceptible to tripping. So every person that trips and they say, I'm such a klutz, or some relative says, what's wrong with you? Why do you keep tripping? That's your answer. It's not behavioral. I assure you that the opposite side glute medius is weak. And if you ever see them walk, you'd see some kind of waddling. And if you ever check their pelvis height, you would see they're not level. So this is what makes man. And by the way, let me just point one concept: scoliosis. Everyone thought, why do I get scoliosis? So let's look at this a second. Okay. So here's your pelvis. Now, this is the sacral spine right here. This is the bottom of the spine. And you'll notice it's attached to the pelvis at the SI joint, sacroiliac. That's how they're connected. Now, when this is level, what's the spine? Perpendicular to the ground. What if this drops? What's going to happen? Your spine's going to go that way. Is anyone going to walk like that? No way. Body would never allow it. So you're going to find your torso trying to come back to your midline. What's that thing called? Oh, that's right, scoliosis.
Scoliosis. And it's really just your body compensating for a weak muscle. Wow.
The majority of scoliosis. And I wrote something. People went berserker when I said this. I did a post on YouTube, and I said scoliosis does not cause pain, and people went berserk. I just had a lady I was just talking to, and she's like, "No, scoliosis does cause pain because I have scoliosis and I have pain." That's correlative theory. When you say the word scoliosis, is scoliosis a tissue? Let me check that anatomy chart. Wait a second. No, scoliosis isn't. So therefore, you can't say it in defining a proper diagnosis that scoliosis causes pain. What are they really trying to say? What is person getting coerced in?
Need a lot of treatments, maybe.
Well, what's the tissue that they're trying to convince you of? It's your vertebrae.
Yes.
It's your vertebrae. So how do you fix a vertebral problem? I got to put a rod in your spine, right? Okay. Well, vertebrae are bone, if I remember correctly. And what's the only type of mechanism that would cause a bone to elicit pain? That would be Fracturing. That's right, fracturing. So with the scoliosis person, is there any fracturing? No fracturing, just a misalignment of the vertebrae. So someone explained to me how misalignment of a bone causes the bone to elicit pain. It can't. It's impossible. It's a lie. It's made up, right? What's really causing pain is the attachment of the muscle to the bone. The scoliosis is being caused because muscles are not working properly.
The scoliosis is the effect, not the root cause.
You got it. Scoliosis is a symptom, just like pain, of muscle weakness or imbalance. That's the magic answer.
Love
Next. It. Isn't this fun?
So fun.
God, I love teaching. All right. All the back people, all the people with the lower back problems. Here's your lumbar spine. This is a muscle called the psoas muscle. You'll notice it attaches from all five lumbar spine through the pelvis to the inner hip joint. If that muscle were to shorten, instead of having if this is your back, a normal lumbar curve, you're going to have an excessive lumbar curve. What's happening? Remember, the psoas attaches on the inside of the spine, not the back of the spine, the inside, and it's running through the abdominal cavity to the hip. So if it was to shorten, it's going to take this arc and it's going to pull it down this way. It's pulling it in. So when you see this, the psoas muscle is shortened and it could actually elicit pain. Where? At its attachment to the side of the spine. So when you have pain at your spine, you have to say to yourself, is it a vertebrae? Well, do you see fracturing? No. Is it a herniated disc? Oops. They may have neglected to mention to you that disc is fibrocartilage, just like the labrum in your shoulder and your hip and the meniscus in your knee. Oh, that's right. Fibrocartilage doesn't have pain receptors. So,
wow.
Yeah, that was a big one that they seem to neglect. Although, if you start to go out, I think it's finally been accepted. No more with the herniated disc. It's whether a question of whether a nerve root's being impinged on. And in terms of the nerve root, each nerve root innervates a certain area of skin, and the lumbar nerve roots innervate the leg so they can create pain at the back. So it's more apt, as I said, to be your psoas muscle. 90% of people with lower back pain, it's that. And by the way, is it an accident that the person with the back pain, instead of having a normal arch, has an excessive arch? Or is this a corroborating symptom along with the pain that, in fact, the pain is coming from a shortened psoas muscle? What if I then checked the flexibility of your psoas muscle and I saw that it was extremely shortened? What if you told me that if you're sitting, eventually you have so much pain, and if you try to stand up, you got to put your weight, you got to put your hands on your thighs to help you stand? Or is that just arbitrary? It's independent. Just get the MRI. It's stenosis. Forget everything. Don't worry about the arch. Don't worry about the flexibility issue. Don't worry about the problem you have standing up. No, it's just that. No. Everything I just described are symptoms. Your body is telling you.
The MRI is finding symptoms, not the root cause.
The MRI is just finding structural variation. It's like saying, not you, but let's say I find an 80-year-old person and they're all wrinkled. And I said, oh my God, you've got wrinkles. You need skin grafts. You got to get skin grafts. My God, that's a deformation of the skin. Oh my God, it's not what it used to be. You must get it corrected because it's not what it used to be. Folks, that's what the herniated disc, the stenosis, the impingement, the meniscal tear, the labral tear are. They are just like wrinkles internally. They're just due to wear and tear. They were never creating pain. How do you know that's for sure? Okay, well, when was the MRI created again? That was the late 1980s, right? What if I told you, huh?
Really? It's that new?
Yeah, it's 40 years, MRI, 40 years. That's all that's been used. Studies shows post-mortem, right? After death, they're going to open people up because they don't have x-rays and MRIs at this point. 1950s, 40% of the population had herniated discs. 40% of the population had herniated discs. So I don't understand. You just told me my pain was coming from a herniated disc. And yet 40% of the population had herniated discs in the 1950s, and there wasn't a single outcry of pain. Nobody was complaining of pain. Well, you got to explain it. It's real. That's real. Everything I talk about is empirical. You could talk all you want about MRI, but that's just pie in the sky fantasy stuff. What you really want to look at is the person. What happened? What's empirical? 40% of the population in 1950 post-mortem herniated disc. Explain it. And the answer is, what did I just tell you before? This material is made of fibrocartilage. It can't elicit pain. That's why no one was complaining. That's why the person who's complaining of pain at the time they're having the identification of the herniated disc, you must assume that it's another tissue that just approximates the disc that's in distress, eliciting the pain.
Very tricky.
Like a muscle.
Wow.
That's the big jump. That's where we have to get. And then the last one just really talks about the knee. You can see the quad attaching to the kneecap here. This is a very popular thing that causes pain at the knee, is the iliotibial band. That usually breaks down because that hip muscle on the other side over there is weak. So usually as I'm doing my diagnostics with people and explaining things to them, I think I'll always say a picture's worth 1,000 words. So that's why I have these here. I'm talking to the average person. I'm showing pictures. A lot of times I go on my phone and I'm showing them. By the time we're done, I hate to say it, but the layperson could give a dissertation to any doctor about what's causing their pain. And I need it to be that way. I have to protect them.
So important.
Yes,
You need to understand what's going on.
Yeah.
Now, what are some things that we can all implement in our daily lives to avoid developing chronic pain?
So if what I've said makes some sense to people and they're recognizing that he's kind of true. I used to have this job and now I'm an IT person and I sit all the time. The very first thing, if you're willing to acknowledge 98% of pain is muscular, is stay active. That would be the first thing. Find activity that you could do. Okay, let's say this person is an IT person and they're in an office. Why can't you 2 to 3 times a week, 2 to 3 times a day, just get up, walk around the block and come back and do your work again? First off, maybe it probably will clear your head from whatever the craziness that you're involved in. By the way, I mean, there's nothing wrong from a psychological, emotional, and spiritual end. You know, taking 2 times a day to clear your head and just try to forget about things, that's just as important.
Absolutely. And the fresh air and the sun.
All of it. Exactly. Exactly. Getting vitamin D, right? That's a big complaint people have today, right? So doing something like that. Try to stay more active. Recognize you will sustain the strength of your muscle by sustaining activity. So that would be a good thing. Now, let's say you do get to the point of having pain. My God, the first thing I want you to think about is the pain associated with doing an activity. Can you say that the pain begins if I sit too long, stand too long, kneel, climb stairs, reach behind me, any of this type of stuff? If you say that, please believe the tissue in distress is muscle. You must accept that. And if you do accept that, this is a hard pill to take, and I understand that. The high probability is anyone you go in the medical field will not be able to diagnose and treat it properly. And listen, I don't want to be this guy. I never wanted to be this guy. This thing has tortured me over 3 decades. But the reality is, I know something that is irrefutable, theoretically, clinically, scientifically pure. It is the truth. And so I hope at some point to be certifying people and making this become vast, and hope that physical therapists and chiropractors and massage therapists and personal trainers want to endorse this and it becomes it. And then I disappear from the face of the earth and I'm left with knowing that the Yass method is available to everybody.
Yeah,
but until then,
a way of life.
Right, exactly. And so until then, you got me. And so if you think that your problem is muscular, I can only suggest that you schedule a Yass method Zoom session. You can do that through my website. The beautiful part about these sessions are that they are a singular session. You get the diagnosis you need. You confirm it's muscular, figure out which muscles it is, learn how to do the exercise, learn how to use progressive resistance. It's videotaped. Then you go on over the next 4 weeks to do the exercises only 3 times a week. Anyone who tells you to be exercising to resolve your pain 7 days, that's crap. That doesn't make any sense. The muscle needs to heal and grow. So it's only 3 times a week. And then we just do a follow-up in 4 weeks. And we follow that process until you're pain-free and fully functional. So it's not like I'm looking for you to constantly be coming back to me. It's I'm looking for you to get you the right diagnosis, the right muscles, understand how to do the correct exercises, understand how to use progressive resistance, make sure you fully understand it, and then let you have the ability through the videotape to be supervised to get the strength you need, because ultimately that's it. That's your problem. You got to get your force outputs up until the force it's greater than the force requirements of your activity. So, and then every 4 weeks you get a follow-up. I mean, it's my recommendation. It's all I can do at this point.
So we can find you, like you said, in your website if we'd like to book on, it's livewithoutpains.com. And I'll post that link below for everybody that would like to check you out.
Yes.
You've gone over kind of, what we can expect. We can, even though you're based in Florida, we can still do this, treatment with you via Zoom, which is amazing.
I've treated people in Taiwan, Portugal, Scotland, England, India, all over. I was doing Zoom before there was a Zoom. I was doing Zoom. I've been doing teleconferencing with Skype for 6, 7 years at least. Partly because my books are published by Hay House, which is the second largest publisher in the world. They're available here, Canada, England, South Africa, Australia. So just by creating awareness through that system, I was being contacted, and I don't expect anyone to fly to Jacksonville for a couple of sessions. It's insanity. So you had to come up with a way of providing this that was accessible. And so it's been years. And I really want people to understand, a lot of people are going to be hesitant because they're going to say, well, how accurate can he be? How accurate can he be if I'm not in the room with him? You have to understand that if I thought that the reason you were having pain in your left hip region was because you strained that muscle, you could stand and I could tell if you're standing properly, 50% weight bearing on each leg, your nose should be directly centered between your legs. I could tell you if it's 1 inch to 2 inches off by looking at you. My understanding is so astute. I could watch as you walk, and I could tell if your pelvis is maintaining a balanced position, a level position, or if it drops that much, just that much. Or if I notice your head or your shoulder go that much over as you're taking weight, which is on the right leg, which is telling you that glute is weak. It's not the in person that's important. It's the ability to discern the slightest variations in movement, posture, flexibility, all that stuff. That's what this is about. And 28 years is a long time to be perfecting this, 3 decades. But that's it. And it's what makes it really be effective.
Well, that's exciting. So as I mentioned before, I've been living with chronic pain for way too long from a car accident. And it gets to the point where it is, it can be debilitating, where it's hard to walk. So I'm going to be booking a session with you to see if,
Awesome.
We can work through this and, correct it and get rid of it, get it out of my life for good. I've tried so many doctors and therapists and, none of, I've gotten some temporary relief, but it's never taken away. It always kind of comes back. So I'm really excited about working with you. And we are also going to do a vlog with it. So everybody out there can watch my progress and my sessions, so you can see how my progress goes. So I'll keep you all posted on that. And I'm very excited to start with Dr. Yass. But thank you so much for joining us today. I learned so much. And I really appreciate you and all the work that you are doing to help everybody get rid of their horrible pain.
I just want people to understand that it's highly unusual to end up in the situation I'm in as someone who seems to have this singular understanding. And I really believe I'm being used for a higher power. Sometimes this sounds a little wacky and maybe out there, but I truly believe. Why was I of the hundreds of thousands of people who have gone through the same exact education, why was the one that asked the simple question, where's your pain? Which led to the sense that something's wrong in what I'm being taught. I need to go on a different path. And that's why I believe that this is my responsibility. And I really, really want to end the horrible, horrible plight of chronic pain globally. And I will do just about whatever it takes. I'll wear a clown suit and nose, man. If it makes more people aware that there is this path, then I'm going to do that. So thank you, Christy, for letting me be on here. And I hope people listen, take it seriously, and are willing to take a shot and see. There really
Yeah.
is a way of ending pain and being pain free and having the life you justly deserve. So thank you.
Yes, well, and I'll be the guinea pig here too
Yeah,
and try it out, and everybody can see how my progress is, and I think that will speak volumes as well. So I'm
thank you.
excited about that journey.
That's great.
Anyway, thank you again. All right, guys. So remember, knowledge is power. The more you understand about your body, the better you're able to stay healthy and prevent disease. Just a reminder, I'm not your doctor. Don't take this as medical advice. If you have specific questions about your specific healthcare, feel free to reach out to your practitioner. If you like this video, please like and share with others. This information could really help someone you may know. Also, hit the subscribe button. Be sure you don't miss out on our future shows. And stay tuned for the next episode of Discovering True Health.